I would like to introduce the first speaker, Dr. Waldman. And again, she's going to be talking about Mohs surgery. Thank you. Thank you, Abby, for joining us tonight.
Thank you for having me, Ann. Okay, so I'm Abby Waldman. I'm a Mohs surgeon at Dana-Farber and Brigham and Women's Hospital. I work with three other wonderful Mohs surgeons, Dr. Chris Schmaltz, Emily Ruiz, and Capisano. I'm going to talk about what is Mohs surgery and what is the role in advanced squamous cell and basal cell. I have no relevant disclosures. So this patient is a gentleman who came in to see us, and he has about a 2.5 centimeter lesion on his right forehead. It had been biopsied and showed a moderately differentiated squamous cell, which just means some features were a little dangerous, but not something we would really get too worried about. He underwent Mohs surgery. Uh, Mohs surgery is a procedure that I'll discuss in more detail where we check the margins at the time of surgery. And how it differs from other forms of skin surgery is that we're actually checking the entire margin. We're checking the side margins and the deep margin. And we get a result in about 40 minutes to an hour, depending on the size of the lesion. The Mohs surgeon is the same person who takes out the tumor as the person who reads it. And so there's a great ability to identify where tumor cells still exist and go back and take more. The difference between traditional surgery, if you had, let's say you had a tumor and you had it cut out and sent to a pathologist, and Mohs surgery is that traditional surgery processes the tissue in a bread loaf manner. And you can imagine it similar to a loaf of bread where slices are being cut, and some of those slices are being analyzed on a microscope, under the microscope after processing, fixing. And it usually takes anywhere from 1 to 7 days to do that. Now, the downside of that is that there's only a representative margin. So you're taking sort of small samples and kind of assuming that they represent the entire piece that was taken out, but it ends up being about 2% of the margin. What we do in Mohs surgery is we go around the tumor and ink it and process it by actually laying the edges out flat. So you take this piece of tissue and kind of lay it down flat on the on the slide so that the entire peripheral margin can be seen as well as the deep margin. That is processed instead of cutting it like a loaf of bread. You actually cut it below from the bottom up. And that's called en face processing. And then it's processed with frozen sections, which take, again, about 40 minutes to an hour. So you get a result very quickly. So this is a great way to check margins, whereas the traditional pathology method is very good for diagnosis. So that's superior for diagnosis with better clarity, but Mohs surgery is better for margins seeing the entire tumor and the entire area. Mohs surgery has reported higher cure rates for a wide array of skin cancers, but specifically for high-risk tumors, can reduce local recurrence, local metastasis, and even death from high-risk cutaneous squamous cell carcinoma. And here's again just another view of that same comment, that Mohs decreases local recurrence and disease-specific death compared to wide local excision. So there are a lot of, besides improved cure rates, there's actually a lot of benefits of Mohs surgery just for patients in reducing patient risk and improving quality of life. So traditionally, a tumor like this, it's very difficult to figure out where the edges are. Where are the margins, right? We see the tumor clearly, but there's also all this redness in the background, and that could be tumor or it could just be inflammation around the tumor. And so if this patient were to go to the OR, the surgeon would kind of have to guess based on the literature, but sort of take an area around and either close up that defect and risk having positive margins in the OR, or do a delayed closure where they leave it open and then the patient would have to go home with a bandage. And then once the pathology came back, go back to the OR for a second procedure. The additional benefit of Mohs surgery is it's all done under local. So instead of going to the OR, we inject lidocaine, which provides anesthesia. So there's no anesthesia risk for that, or very minimal anesthesia risk with local. And then again, a local, you don't need to go to the ORs. You don't need multiple visits coming back and forth. Additional benefits of Mohs surgery, which should not be underscored, are there's a potential for smaller or less complicated closures, or even just letting it heal on its own. And that's because when we check the margins the same day, we can take a smaller margin and potentially lead to a smaller defect and thus smaller line of stitches. So that's, everyone wants a smaller scar, a less obvious scar. The additional benefit, same day closure. Again, not going home usually with a big bandage in the vast majority of cases, or not having to change the bandage. Often, usually the stitches close that wound up. And then just to know, a lot of times people think of only plastic surgeons being the surgeons who would close large defects, but actually most surgeons undergo significant training in order to do basically facial plastic surgery for the vast majority of lesions. So here are just some other examples of cases that we do as Mohs surgeons pretty often. This is a forehead flap where we would close for a defect on the nose. You can see this large defect on the cheek, closed with a large bilobe, with pretty good results at 6 weeks. So the last benefit of Mohs surgery that we'll talk about is staging and cancer management. So one thing that a lot of people don't know is that most staging features in skin cancer are actually not known prior to surgery. And the reason for that is that usually when you go to see your dermatologist, they'll take a very small sample of the tumor. And while that is good for establishing the diagnosis, it doesn't always tell you every single high-risk feature of that tumor. And it's not uncommon for us to, as Mohs surgeons, find other features while we're operating. And those include the depth of the tumor. It includes involvement of nerves, involvement of lymphatics or blood vessels. It could be sort of what that tumor looks like. So some tumors have features that make them more aggressive, or you can even find out during surgery that it's invading bone or muscle. I won't go into detail about this, but this is essentially how we tumor stage cutaneous squamous cell carcinomas, or head and neck skin cancers on the head and neck. A lot of it has to do with size. So again, 2 centimeters is kind of a sort of a magic number when establishing sort of higher versus lower risk. But then as you get to the even higher risk skin cancers, the bigger the tumor is, the worse it is. But then depth has a big part, nerve invasion, and bony erosion. All those things I already mentioned that often can't be established until we actually do the surgery. This is just another method of staging, just to know that there's sort of 2 ways that we think about staging these tumors into high risk and low risk, and it very much impacts how these patients are treated. So here's just an example. This is a patient who was immunosuppressed, had a kidney transplant with a rapidly growing 3-centimeter squamous cell on the preauricular area. And during surgery, we actually were able to see that there was large caliber nerve invasion. So this, what I'm pointing to here, is actually the visible nerve. And then I can see it under the microscope as well, with this being the nerve and this actually being the tumor all around it. So we kind of have a real-time staging mechanism. This is just to show that patients with Mohs surgery do better. If they have squamous cell with PNI, they do better with Mohs surgery than wide local excision. There are features that we can see as Mohs surgeons during the surgery are tumor in a blood vessel. And so this is a rare finding. We don't see it very often, but see it enough, probably a few times a year, where the tumor is actually going through a blood vessel. Sometimes we see it in the lymphatics, or actually invading into the blood vessel wall. And that very much affects how we think about the outcomes and prognosis of that patient, and can titrate the treatment. Usually send them to my colleagues in radiation, or Dr. Silk in oncology. Other things that we can see during the Mohs surgery. So these are basically just pictures of what I see when I look in the microscope. And this is, it might not look much to you, but to us, it is a very bad sign, where all this scarring, all this white in the background of this tumor is a sign called desmoplasia. And I can even see from here, from high power, that there's some tumor wrapping around the nerve. Of course, we would go in closer and take a look at that to confirm. This is also a sign that the tumor, again, you look at many, many, many of these and you start to know, this is a bad one, while other ones are not as bad. So we can see things under the microscope that really help guide therapy. So this is just an example of, I'll quickly go through this last point of how we work as Mohs surgeons with a multidisciplinary team that's here. So this is an example of a basal cell that was invading into the nose, which can happen when they're left for long periods of time, or if they're rapidly growing. In this case, the Mohs surgeon was able to clear, this is not my case, but Dr. Chris Schmaltz, she was able to clear the periphery. And that's important because, again, you don't want to go into the OR and not know what margins to take. So in this case, the Mohs surgeon was able to figure out where the edges of the tumor were. But then that patient went and saw one of the head and neck surgeons, who went and then cut the cartilage and part of the nasal bone out, and was able to clear the tumor in the OR. So it's kind of a combined effect. So sometimes we work with other surgeons when we can't do all the surgery under local, or it's not appropriate. So in this case, again, that patient underwent further resection in the OR after the margins were cleared, had closure with the head and neck surgeon. And we were able to follow the patient for every 6 months with imaging. And at 1 year, patient was doing quite well. So this is, again, a very extreme case where a similar thing, where if this patient with this extremely large tumor were to go to the OR without the edges being cleared, it would be very difficult for our colleagues in head and neck surgery to figure out where the edges are. And so the Mohs surgeons can play a role in doing what's called a moat Mohs surgery. We don't take the whole thing out. We just kind of establish where the borders are in order for that patient to achieve clear margins when they go to the OR, which is what this patient did. And again, this case was the case that we identified, that Dr. Schmaltz identified the tumor in the blood vessel, and they did end up undergoing further treatment that they wouldn't have otherwise undergone if that had not been discovered. And so again, we usually will put in temporary stitches before sending to the OR to undergo further resection with our colleagues in head and neck surgery. These are kind of gruesome pictures, but he underwent a pretty significant surgery and reconstruction, but doing well now. So in conclusion, Mohs surgery is a way to achieve clear peripheral margins and deep margins using same day frozen sections. We read the tissue ourselves, and it's good for a whole host of skin cancers, particularly on the head and neck, particularly for high risk skin cancers or high risk patients, and has many benefits to our patients.